Cancer is one of the words that you never want to hear as a diagnosis. And retinoblastoma, a cancer that occurs in children, is one of those diagnoses. According to statistics, 8,000 children worldwide develop retinoblastoma each year, and it affects children who are less than 5 years old. So this is a very serious condition. And every parent, every caregiver should know about this. And so today we'll be exploring this topic, looking at who gets it, how do you know your child has it, and how do they treat it? And so this is the Dr. Tebz show, where we're putting your health back into your hands. Today, to discuss this topic with me, I'm being joined by Dr. Hamzah Mustak. He's a qualified ophthalmologist who's heading up the ocular oncology and oculoplastics unit at Groote Schuur Hospital. And he also has a private practice at the Atlantic Eye Center right here in Cape Town. He has vast experience in this topic, as he's been treating children not only from South Africa, but from Africa. I mean, this is amazing. This man it's an honor to have him on the show with me today. So hi, Dr. Mustak. Thank you for being with me today.
Thanks for having me on the show, Tebz.
Dr. mustak, can you explain, in terms of the anatomy, because retinoblastoma affects the retina, just that our viewers back home understand, what is the retina?
Sure. So the retina can be seen as the camera film of the eye. So it's the layer on the inner lining of the eye that's responsible for taking the image that you see, or the light capture, and converting it into electrical signal that's sent to the brain. And so it's made up of these various different cells that are specialized to capture the light.
Okay. Yeah. And so what is retinoblastoma?
Okay, so retinoblastoma is a type of cancer. So it's the most common intraocular, so cancer inside the eye that we see in children. And it actually is the second or third most common cause of cancers in children. And what it is that the maturing cells of the retina, so the cells we spoke about just now, is they undergo an abnormality. So it's a genetic issue that happens. And so the gene that's responsible is the RB1, or the retinoblastoma 1 gene. So mutations to that gene prevent the cell from regulating its growth cycle. And if that happens, then the cell grows rapidly and out of control. And so that's how the cancer develops.
Sure. So then who gets this, and how is it preventable,
So to answer the first question, who gets it, is there two descriptions. So one is a hereditary form, or familial. So it's where one parent may have had the retinoblastoma, one or both parents may have had. And in that case, the child is very likely to develop retinoblastoma because they carry that genetic mutation. The other is the sporadic type. The sporadic type is more common. And it's where the mutation develops as the child is developing inside the womb. And there's no known cause for why that mutation happens. It's a sort of natural mutation that occurs. Thankfully, in the sporadic type, it tends to present with less severe disease than in the familial type.
So what you're basically explaining, so that we make it simpler for the viewers at home, is that it's something that you can't prevent it because you are born with this problem.
Absolutely,
it's in your actual. When you say genes, can you explain that? I know this is a very funny way. This is a very funny question, but how do you break it down to say genes? Because some people don't understand, what is a gene? What is this thing you're talking about?
So the cells in our body contain DNA, which is the sort of the blueprint for what those cells need to be and do. Yes. And so we carry that blueprint. It's inherited from our parents and from their parents and passed down. And so if there's an abnormality in that blueprint, which is what we call a mutation, then it can affect the way the cell behaves or acts.
Okay, so basically the blueprint in this retina, that's where the problem is.
Yes, that's right.
And that is why then it's changing. And as you said, then there's the hereditary, which you get from your parents, and then the sporadic, which just, it happens. You're the first one in the family to have this problem.
Yes, that's correct. And so that's one of the issues, is that with those that run in the family, you tend to know that we need to screen the children for that condition, and so we can pick it up early. in the sporadic type, because it doesn't run in the family is not aware that it's a potential problem. And so a lot of the patients that we see here, especially in Africa, often present later because of a lack of awareness or understanding of the condition.
Yes, because they just think, well, nobody's ever had this. Why is my child now the first one to have it?
That's true, exactly.
Yeah, exactly, and that's where the problem is. So then how does a parent know that their child has retinoblastoma if, for example, as you're saying, the most common type is the first one in the family, the sporadic type? So how will they know that actually my child has this problem?
So the most common way that it would present is with what we call leukocoria, which means a white pupil. So just to try and explain that for people who wouldn't understand the terminology, is whenever you've taken a photograph of someone, you sometimes capture that the red sort of shininess that's in the pupil, or what we call the red reflex. And so in these kiddies we develop, because the tumor is growing inside the eye, it might change the appearance of that reflex. So it would appear as yellow or white. So parents might notice in certain light conditions that they see a white reflection on the inside of the eye. Is one of the more common presentations. The second most common presentation is the development of a squint. So where one of the eyes turns in or out or deviates. So it's what we call strabismus, or more commonly known as squint, is the second most common presentation.
Yeah.
So if those things develop which were not there before, then that should sort of raise concern that the parents should take their child to either their GP pediatrician as a start, just for a screening. And
yeah. And just to take a rabbit trail off of this, is that we see parents presenting late. And I think majority of the time when you ask them, they say, but I took my child to the nurse, I took them to the clinic, and they keep saying, no, but just use this ointment, use this ointment. Have you found that in your experience? Yes,
absolutely. So, and it's part of the big issues that we need to address in developing or under-resourced countries, is not only education of the parents and the general population, but education of healthcare providers. Because often in these settings, especially in the more rural areas, they're nurse practitioners who run the clinics and provide healthcare. And it's important that we sort of educate the broader health service, because it is a fairly uncommon or rare condition as far as eye problems go. It is potentially devastating and life-threatening, and so it's important that we raise awareness and improve education around it. So India is a good example of that. So when you look at what a country's retinoblastoma issue is whether it's a management related or is it educational and social related.
Yeah.
And I think in India they ran an awareness campaign which was three-pronged, so targeted at healthcare providers like GPs, targeted at nurses, and then targeted at the general population.
Wow, that's amazing. So like now, the parents realize that the child has a white pupil, they come to you. You are now going to treat them. So what can they expect, because a lot of people are like, they're going to take my child's eye out, or they're going to do this horrendous thing. What can a parent, expect is going to happen when they come to you for help?
Okay. So once this is picked up, we need to make and confirm the diagnosis. And so we often need to examine children. One of the problems is that children can be a bit tricky to examine because the eye is a sensitive area, and it's a scary thing for a child, to have someone approaching their eyeball.
Exactly.
And so what we do, to make that easier for them, we do the examination under anesthesia. And so in order to evaluate the what's happening inside the eye properly, we need to dilate the pupil or make the pupil larger. So we instill drops in, so it allows us to see into the back of the eye. So at our center, we will examine the eye and then take photographs and then confirm whether this is the diagnosis or not. And if that is the diagnosis, then we'll obviously start instituting the management plan. So the first step in that would be, because we've confirmed that this is a cancer, so most people will sort of understand that if you've got a growth in your body, the doctor usually takes a biopsy and they make the diagnosis based on the biopsy. But because this is occurring inside the eye, it's not something that we can biopsy. So it's a diagnosis we make by, what it looks like in our clinical judgment.
Can you explain what is a biopsy?
Okay. So a biopsy is where they will take a piece of the tissue and send it off to laboratory, where the pathologist or expert looking at those cells will look at it under a microscope and then determine whether those cells are abnormal or normal.
So here we can't obviously do that, as you said, because it's in the eye.
Yes.
All right. So now, how would you treat it?
Okay. So because it's a cancer, the most important thing is to work within a team, a multidisciplinary team. So that will constitute the ophthalmologist or the ocular oncologist looking after the patient, as well as the pediatric oncologist, as well as a radiation oncologist. And part of our team is also the social worker, psychologists, who form, part of a multidisciplinary way of approaching this. So the first step with most cancers, it would be what we call staging. So it would be to determine how far along the cancer is. So whether it's confined to one eye, is the tumor in both eyes, and in retinoblastoma, you get a condition where, it can potentially affect one of the glands inside the brain. So we need to look for whether those glands are involved, as well as whether they're spread to the rest of the body. So once we establish what the staging is based on that, then we institute the treatment for that.
Okay, all right. So this treatment, is it dangerous? Is it safe? It doesn't need an operation. What type of treatments? I know there's many options, Dr. Mustak. But just to give parents an idea, like, what is this treatment?
Yeah, so in broad terms, once again, if you go back to what the staging is, so if it's confined to one eye, it's possible to treat the tumors in that eye with what we call local treatment. So that involves using things like laser treatments, or freeze, or what we call cryotherapy, or freeze thaw treatments, or sometimes even focal radiation implants to treat the tumors. If it's more advanced than that, then we may need to work with the oncologist to giving chemotherapy to the children, and that's often the case in where both eyes are involved, and so they'll undergo a course of chemotherapy. So because it's a cancer, the treatments themselves can also obviously affect the child, and so we have to be aware of that. But if we look at oncology treatment, it's come a long way over the years, and so now we've got newer drugs that are fairly well tolerated. Obviously the kids have to be monitored by the oncologist for complications of the medication, but we're very good about making sure that they are monitored regularly to make sure the tumors are responding, and that where possible then we can treat the tumors both with laser treatment as well as the ongoing chemo. But in severe cases we may need to operate on those patients, and unfortunately with this kind of condition, those operations are destructive operations, so where we have to remove the eye because that's the source of the cancer. And that would be in advanced cases, and often where the eye has been destroyed by the tumor, and so it's often difficult to explain to parents, and understandably, to have to do this kind of operation, because we would only do it in cases where we know that there's either no visual potential or that there's been extensive damage to that eye.
No, that's true. And so once you remove it, then obviously you give them an artificial eye. But after treating them, does this mean, oh, it's gone, the cancer's gone, and we can move on with life? Or does it mean it's a lifelong, seeing the doctor all the time? What's the journey of a parent after you've done the initial treatment?
No, it's a fantastic question. So I think when we look at terminology for cancer, sort of the general population can understand, we always talk about things like in remission or it's cured.
Yes.
So retinoblastoma is not one of those cancers that has a cure. So if we think about how it develops, you have what we call immature retinal cells as the child's developing. We call those retinoblasts. And so that's where the mutation in the DNA profile that we spoke about occurs in those cells, and so they start to replicate out of control. So the problem with that is that is that those cells continue to mature
Yeah.
over time up to the age of 6. So they're always immature retinal cells lying around until the child is fully developed, the retina is fully developed, which occurs between the ages of about 6 and 8. So the initial treatment, if they're receiving chemotherapy, is often for 6 months. So that will treat the tumors that are active, but it doesn't prevent the formation of new tumors from the other immature retinal cells. So that's why it's important that we monitor those patients over time. So in the familial ones, where often they're bilateral, so both eyes are involved, those children are also at risk of developing other cancers over their lifetime.
Wow.
And so it's important that we monitor them throughout life to try and pick up or detect these cancers earlier so that we can treat them earlier.
So this cancer really can affect a person's life altogether. And you know, we were mentioning about the siblings, you know, that the brothers and sisters can get them, can get it, and the children, their children, as in the person who has it can also get it. Can you explain a little bit about that so that the people can understand what we mean when we're saying, you know, it's genetic, it's hereditary?
Right. So when we talked about your DNA profile and genes that is passed down from parent to child, and then inherited also from the parents' parents, and so when that mutation occurs, it's imprinted in that the DNA profile now, and so there's a potential chance for it to be passed on to each generation. The funny thing about genetics is that we get 2 copies, one from our dad, one from our mom, usually. And so it depends on the combination of that. So with retinoblastoma, you've got 2 of the RB1 genes. So in order for that to develop, you need both of them to be abnormal. So how it's inherited will depend. So in familial cases, we have to look at which parent was involved, one or both, and then based on that, it'll obviously be a higher risk or chance that their child will develop retinoblastoma. And if that's the case, then we do early screening for any patient who's had retinoblastoma who's now having a family.
Yes.
So we would screen those children earlier on, as well as their siblings, and so we often work with a genetic counselor as part of our multidisciplinary team, because if it happens to parents, you know, it's a tough and difficult journey because it's multiple treatments and, you know, ongoing treatments, and it takes its toll on the sort of family dynamic and infrastructure. And so, and they will want to know what are the chances that if they have another child that this would happen. So we'll often discuss it in conjunction with a genetic counselor, and now it's possible to actually do testing for the genetic mutation and then provide a more informed or accurate sort of risk assessment of the chance of that happening.
Yeah. Okay, so the one and final question I think every parent wants to know is, can this condition kill my child? Will my child die? Can they die from this? Or if I don't want to do treatment, you know, we can just all move on? Is this, I mean, what is the implications?
Yeah. So it is a cancer, and cancers are, it can be aggressive and spread to the rest of the body. So this is something that needs to be treated. Otherwise it will. You know, if it spreads to the rest of the body, there's a chance that the child will die without treatment. And so just to add on to that is that if you look at retinoblastoma management in the developed world, so countries like the US and the UK, the survival rate for children with retinoblastoma is over 95%. So if we look in Africa, the survival rate for children in Africa is less than 30%. So it is a treatable cancer with good survival rates if there's access to the right level of care, and if the patients present early enough that we can treat them without it spreading, that the survival for these children is good. But it's important to know that if it's untreated or with late presentation, it is fatal.
Yeah. No, the reason why I mention it is because I remember one patient I had who They had presented to one hospital and then they disappeared for 6 months when they heard that they have to take the eye out then, because they presented very late. And so they rocked up at my practice in government, and now this tumor had really grown. And that child, I lied to you not, died within 6 months. I'll never forget. Came in on Christmas, around Christmas time, fitting, like they're having seizures, and then just did not wake up.
Absolutely.
And gone.
And I think as providers of a service to treat these patients, that's often the sad thing, is knowing that there was treatment available and it was a preventable death.
It was a preventable death, because I did tell them that, you know, I had like 4-year-olds now who had lived past it, and they were surviving and thriving and continuing with their treatment, and you know.
But, but it is a difficult topic of discussion, because one of the issues I faced in my career treating these patients is being sensitive to the cultural beliefs. Yes. So it's easy presenting in a Western model to say we need to remove the eye, and you understand that you're going to save the child's life. But here in Africa, where we've got, you know, many different beliefs ranging from traditional to religious, to a combination of those, is being sensitive to the issue. So in the beginning, I couldn't understand when parents didn't want to do this life-saving procedure. And it's only from sitting and counseling and talking to them and understanding their cultural context, which is obviously important for their family dynamic. And so I think one of the important things as an African ophthalmologist treating these patients is being sensitive to that and trying to work within that framework.
No, I completely agree with you, because it is tempting to want to just push and say, but it does take time to win the parent over. So, drmustak, this has been a very riveting conversation, and I think an eye-opening conversation. And I think a lot of viewers back home are going to be more aware, and, you know, what's the word, intentional about dealing with this leukocoria when they see it, or a new onset squint. So in closing, what are your parting thoughts for our viewers back home? So, I mean, just to summarize, it's one is that it's a cancer that's potentially fatal. We don't have a cause for it. There's no reason. There's nothing you can do to prevent it. But now that we've spoken a bit about how it would present, is just to be aware of those things. And if you do notice them, that you access healthcare as quickly as possible. And often it's I've had situations where my patients know more than I do about a condition, and it's important that we don't let egos get involved, and I learn from my patients. And so one of the things is, it's important that if parents know this, that even if they're told by a sister at the clinic or a GP that no, it's going to be okay, if they're armed with the knowledge, they know better, and they should persist and insist that the right person eventually sort of sees their child and makes the diagnosis. 100%, because their health is in their hands. Exactly. So thank you so much, Dr. Mustak, for joining me today. Pleasure. Thank you for having me. And viewers, thank you so much for watching this episode today. If you'd like more information about this topic, or you want to know how to get into contact with Dr. Mustak, we'll leave all those details in the description below. And please do remember to like, share, subscribe, and push the notification button so you know when we post our next episode. So remember, please do take care of each other, take care of yourselves, and remember, your health is in your hands. God bless.